Hi, everyone. Thanks for joining us today. This is Jennifer Gross at PointRight. We're happy to have you with us for the next hour or so as we talk about COVID-19 and all the various permutations of regulatory updates that have been flying at us fast and thick over the last few months, and the potential downstream compliance implications that SNFs should watch out for as the situation hopefully resolves sometime in the near future. So just a couple of housekeeping items before we get started. All the audio lines are muted. If you have any questions for us, there is a chat that's built into the GoToWebinar toolbar, so you can type in a message to us if you have any questions. We'll do our best to answer them, and if we don't get to your question, we will follow up with you through email. There's also a handout for the presentation that's also attached to the webinar toolbar, so feel free to click on that and download a PDF of these slides. So again, my name is Jennifer Gross. I'm a senior healthcare specialist at PointRight, and joining me is my colleague Pam Kaiser, who is our VP of Provider Services here at PointRight. So before we get started, we do have a little disclaimer because the situation with COVID-19 is evolving so rapidly, and there have been a lot of changes and updates, and they continue to, CMS continues to kind of tweak the regs and find new areas to focus on throughout the course of this pandemic. That means things are going to change as we go along. So keep an eye out for any changes that will be coming downstream after this webinar is over. And that might include any other updates or any extension of the waivers, or hopefully the lifting of the waivers, which would mean the public health emergency is over, and any other further clarifications on coding key MDS items that are related to COVID-19. So let us move on here. Making sure that my slides are running. They appear to be moving forward on the screen here. Let me try showing it again. Okay, so that was our disclaimer. Sorry about that. Thank you, Pam. So today's learning objectives are to cover the various waivers stemming from the COVID-19 pandemic that are specifically targeted towards skilled nursing facilities and Medicare Part A reimbursement in the SNFs. And we'll also be talking about how Medicare works in general as far as determining a skilled level of care, documenting those requirements to make sure that you are covered, and substantiating skilled services, and what you need to keep in mind with the absence of a 3-day qualifying hospital stay to kick off that skilled Medicare stay. And we'll wrap things up by talking about some compliance risk areas that you should watch out for in any future auditing activities that we're pretty sure will be coming eventually downstream. So the public health emergency for COVID-19, as you know, was declared on March the 13th, and there have been all kinds of waivers, as I said earlier, that have been issued by CMS related to the time frame of submitting MDSs to CMS. We had the Medicare Advanced Payment Program, which everybody took full advantage of right away, so that didn't last very long, but to basically keep facilities up and running and afloat with some much needed income during this time period as they are adjusting to all of the costs that they're incurring by caring for these very, very challenging patients in their facilities. And some other flexibilities that were implemented basically to ease the work burden on skilled nursing facility staff, whether it's doing paperwork and or reporting data to CMS for quality measures, obviously not the highest priority at the moment. And the requirements and usage of telehealth in the facility, which is a long time coming. And if there is a silver lining in this whole terrible situation, is that telehealth is really gaining a foothold in the post-acute care and skilled nursing facility space. And once that starts, we don't anticipate that's going to stop. So with all of these changes, what has not changed is what makes somebody eligible for Medicare in the first place, and what the criteria are for capturing a skilled level of care for skilled nursing facility services. So we'll talk about that because it is really, really important to keep your eye on the ball, metaphorically speaking, so that you can stay on top of things and make sure that you are in compliance after the emergency ends, so that you are not at risk for any audits or takebacks. So let's talk a little bit about Medicare eligibility. Of course, this is going to be a review for just about everybody on this call, but I think it's valuable to level set and just make sure that we, again, don't lose sight of the basics. So first of all, who gets Medicare? Who is eligible for Medicare, rather? Of course, if you're 65 or above in age. And for people who are under 65, certain people with disabilities and people with end-stage renal disease are also eligible for Medicare skilled services. Now, in order to access the specific benefit for SNF coverage through Medicare Part A, there are a few requirements that are technical eligibility requirements that have to be satisfied in order for there to even be a benefit period to access. And again, these are the standard regulations. So there have to be available Medicare Part A days in the current benefit period for that patient or beneficiary, rather. There needs to be a qualifying event, either a 3-midnight hospital stay or another event that triggers the medical necessity for skilled nursing facility care under Medicare. And there has to be a physician's order for SNF services on a daily basis. And, you know, the nuances of, as a practical matter, these services could not be provided in the community on an outpatient basis. It would need the services of the 24/7 staffing and infrastructure of a skilled nursing facility, practically speaking, in order to render the services that this beneficiary needs for their condition. And of course, the other piece of that is that the ordered services need to be reasonable and necessary, both for the beneficiary's clinical condition, the service that is being the services that are being used to treat whatever that condition is, and in duration. You wouldn't be doing transfer training for 100 days because that's not reasonable and necessary as far as the duration is concerned. Now, to keep the ball rolling, to continue skilled nursing facility coverage, the physician also has to certify and recertify that these skilled nursing facility skilled services are still appropriate, reasonable, and necessary, and the reason for those services in the SNF. So that initial certification has to happen at the time of admission to the SNF, or put in parentheses, at the time of the initiation of the Medicare benefit. And then depending on how long the duration of this skilled level of care lasts, there needs to be a first recertification within 14 days of the initial cert. And then the subsequent recerts occur within 30 days of the prior recertification to keep the ball rolling. Usually it doesn't last that long, but there is that standard requirement because a benefit period will go up to 100 days of skilled nursing facility services. So there's a lot of time to play with here, and Medicare's intent is to make sure that the continuing coverage for that level of care continues to be appropriate and reasonable and necessary for the beneficiary. Otherwise, the resident or the patient or the beneficiary, once they drop below a skilled level of care, then the coverage is supposed to end because it's not appropriate anymore for that level of Medicare coverage. Now, when the resident drops skill, and the coverage is ended, there is a possibility for them to re-access the remaining Medicare days in their benefit period. And there are two scenarios when this can happen under normal circumstances. So there's such a thing as a 30-day window where within 30 days of the last covered day, the resident can reattach to that previous stay without having to go out to the hospital for another qualifying event. So there's that piece. Of course, you would have to complete another 5-day MDS, get another order to resume the skilled services, and then you're good to go. Now, there's also, after day 31, past the day that the resident drops below skilled, there would have to be a qualifying event. Under normal circumstances, a 3-day hospital stay, but we'll talk about the 3-day waiver in just a few minutes. So there are ways that you could actually re-access those remaining Medicare days after the resident drops below skill. But again, this is up to 100 days in a benefit period. So after that 100 days exhaust for a particular resident, then there has to be what's called the spell of wellness. And this is 60 days, 60 consecutive days through which no skilled services whatsoever were needed or provided to that resident during that 60-day period. Once you've had enough time to rest, give Medicare a rest for a full 60 days, and if that level of skill does not reach, or the level of care doesn't reach the skilled level for that whole 60 days, then Medicare deems it fit to grant you another 100-day benefit period that you can access going forward. So that's how it works as far as the benefit periods are concerned. So for the skilled level of care requirements, I mentioned that in order to initiate a Medicare skilled stay, there has to be a physician's order in order to kick this off with certification that the skilled care is needed for the resident's current condition. Now we're talking about either skilled nursing care or skilled rehabilitation services. It doesn't have to be both, but usually it's a combination of the two, provided directly by or under the supervision of licensed personnel, whether it's nurses and licensed PTs, OTs, SLPs, and CNAs, or CODAs and PT assistants that are operating under the supervision of the folks who hold the licenses. On a daily basis, nursing daily means daily, 7 days per week. And for therapy, a daily means 5 days a week, although it could be more. Now, the skilled services can't be provided just for anything. So the services must be related in some way to the condition which causes the qualifying event. So you think about the classic example: the resident falls and breaks a hip, or they have a stroke, or something like that. They go out to the hospital. They come back to the SNF for rehab because of that qualifying event. Now, sometimes another condition will arise while in the SNF that the resident is receiving care for that inpatient qualifying event. Perhaps the resident had a CVA, they went out to the hospital, they're bed fast at this moment. Once they enter the SNF, because of their compromised condition, their decreased mobility, perhaps they develop pneumonia, so there's another skilled service that could justify continuing to skill, even though the resident is not able to participate in therapy during that time. That is okay. And as I mentioned, as a practical matter, these services can only be provided inpatient in the SNF and not on an outpatient basis in the community. So, of course, the Bible for Medicare benefits is the Medicare Benefit Policy Manual. Chapter 8 is where SNF services are covered. And my point being, I'm not going to read this whole slide to you because I'm sure you have the whole thing printed out and kept by your bedside for a little light reading when you can't sleep at night. But the principles for determining whether or not a service is considered to be a skilled level of care has not changed. We don't foresee it changing anytime soon. And this is going back for years. I mean, from the transition of different RUG payment models, the transition from RUGs to PDPM, the baseline requirements for a Medicare skilled level of care have not changed. So with all this text on the slide, I do want to point out the area, the segments that I underlined. I added this underlining because the point being that these services require the supervision or direct skilled intervention of licensed skilled personnel in the skilled nursing facility. And the other piece I want to mention is that this does not hinge solely on a diagnosis or a prognosis or any one factor to determine whether or not a service is not skilled, or an audit or a retrospective review, or that a service is skilled. Just because a resident has a specific diagnosis does not mean that they justifies a skilled level of care. So it's about the care needs rather than the diagnosis. Now, the manual talks about 5 broad categories of skilled care. And I think it's always very useful to go back and read through these categories of skilled care because we've been so conditioned for many, many years under RUGs to think of skilled level of care as being 5 days a week of therapy and maybe some nursing thrown in for good measure. But really, the multiple factors that make up a skilled level of care cover the gamut. Yes, skilled therapy is involved. Yes, direct skilled nursing care is involved as well. And you'll see both of these things, even with your COVID patients. But these areas that you are really, really focusing on right now for your folks who are currently infected, who are perhaps being under surveillance right now to determine whether or not they have an active infection, your folks who you're trying to cohort away and keep them from being infected. The whole thing comprises a skilled level of care, and the important thing is to capture this in the documentation so that you are backed up. So if you start at kind of the bottom of the list of observation and assessment, what are you doing? You're evaluating your patients, you're monitoring vital signs, you're checking O2 stats, you're checking lung sounds, you're asking them how they feel, and you're just eyeballing them. Every time a nurse walks into a room or looks through the window at a resident, they're doing an evaluation. It's continuous. It kind of runs in the background of our operating system. These skills that we have ingrained in us from training forward in our experience is the skills of a technical or professional person, and making sure that you are able to document these observations and these assessments is really important. And the management and evaluation as well. You're developing a care plan, you're evaluating how that plan is implemented and how well it's working, you're making changes as needed, you're communicating and coordinating with the physician and the interdisciplinary team. This is all part of your skills. This is the level of care that you are providing. Teaching and training, of course, is another piece of this, whether it's doing diabetic teaching or teaching folks who are recovering from COVID-19 as far as pacing and breathing techniques and things like that. Again, these are skills that we have learned and that we put into practice every day. And then these last 2 bullets I kind of consider, as far as Medicare documentation is concerned, is the easy stuff. The direct skilled nursing services, if you're giving IV medications or you're doing wound care or you're managing a tube feeding or giving nebulizers, you know that you're documenting this stuff, and it's easy to substantiate skilled nursing services. And the same with the skilled rehab services. Your therapists are doing all their regular documentation and the time that they're giving and their evaluation and tracking progress. All that stuff, it's not easy at all in practice, but I think of it as easy because it's what you go to right away in the documentation to look for skilled care, but that's not the whole picture. Off the soapbox now, and I'm going to hand it over to Pam, I'm going to talk waivers for a little bit. Pam?
Great, thanks, Jen, and thank you for that great summation of the sort of the foundation of Medicare and skilled care. And the reason why it's important to keep that in mind is because the 1135 waivers deviate from that a little bit. And so we're going to just walk through some of the ones that are important to know for SNFs. So the waivers were actually, they're issued under the Social Security Act, section 1135, which is why we call them those. And it basically, they only become available to SNF providers when there's been both a declared national emergency and a public health emergency. And usually, historically, we've seen this in areas where there may have been a catastrophic event, a flood, hurricane, tornado, those kinds of things. And it's more regionally based. It hasn't necessarily, at least to my memory, ever been nationwide where they've been declared, when that's been declared for that large of an area. And so what they have is under these waivers, there's a whole bunch of them, and states can apply. They apply to CMS, they fill out a form, they send it over, and CMS would approve the waivers. And so the states can pick and choose the waivers that they want. Or many times what happens is the federal government issues what they call a blanket waiver. And that's typically, historically they've known that these are waivers that are important for the post-acute care providers to have in place in order to maintain the care for the residents and help ease the burden of the emergency. So they may issue blanket waivers on their own. And if that's the case, then states don't need to apply for them. But if they want other waivers or access to other waivers, it's available to them through that application. And we'll talk about two waivers today. One is the 3-day stay waiver, and the other is the MDS submission waiver. Well, thanks, Jen. So if we're talking about the 3-day stay waiver, it's always helpful to understand sort of what the intent is behind a process or policy so you can understand how it's meant to be used. And really the intent for the 3-day waiver is to ease the Medicare requirement of a 3-day hospital stay that allows patients or residents to access their SNF skilled benefit without having to go to the hospital. And the reason that that's sort of important is because when we start to think about, national disasters, floods and those sorts of things, one of the things that folks immediately start to be concerned about is hospital capacity. And we've heard a lot of conversations about the surge, the surge is coming, or it was last week, and it sort of rolls across the country at different time frames. But the idea is that the hospitals are concerned, as everyone, that they'll be quickly overwhelmed and not able to treat people that need care in the hospital setting. And so part of the 3-day waiver is to move people through the care continuum or keep people out of the hospital because they're allowed to be treated in place or skilled in place. Beneficiaries still, they have to meet the skilled level of care, and they can access their benefits, provided all the other requirements are in place. And they can, it's as simple as, they can go to the ED and come back and still be access to skilled care. They don't need to be admitted. We've had hospital admissions, but they're less than 3 days. So somebody could come in, be admitted for 1 day, and then they find a place for them and move them to that location so they can free up the hospital beds. We've seen direct admits from the community. So somebody may go to the doctor's office or something like that and be sick, and then they connect the patient and the family with a SNF, some sort of post-acute care provider, but that it can be a direct admit from the community. And indeed, people who are currently in your SNFs now, who are maybe long-term or custodial care, they can access their benefit need right away, right? They don't need that hospital stay. So the whole goal is really to ease up the burden, move people through the care continuum safely and effectively, and to keep the acute care beds for those that really, really need it. Next slide, Jen. Oh, perfect. So when we talk about the waiver and the 3-day stay, it's just the 3-day stay part that goes away, right? They still have to have all the criteria met for accessing the Medicare benefit. They have to have Medicare. We can't give it to them if they don't have it. They have to have paid into it. All the criteria that Jen reviewed earlier has to be met. And the stay has to be medically necessary. And again, the only thing that's missing is that 3-day stay. So when we start to think about scenarios and how you would apply sort of the guidelines or the rules, if you think about someone who's in your center for custodial care and maybe has, come off their benefit period, so they have days remaining in that benefit time frame. If they are deemed to be skilled again and they're within that 30-day window, you would just pick them up again as per the normal policy and reinstitute their skilled stay with that particular resident. But if we're beyond that 30-day window, where Jen had mentioned you have to have a 60-day spell of wellness in order to re-access an additional benefit days, what they've done here is allow that even if at least one day beyond that, so day 31, has happened and the resident was on their way to completing a spell of wellness, but was delayed or prevented by the disaster in some way, shape, or fashion, you can put them back on Medicare without the stay. And the other thing to remember is that the waiver doesn't grant more than 100 days in a benefit period. And when you look at the information about the waiver that Secretary for CMS has published, it's really one additional benefit period within this time frame. Again, depending on the scope and the duration of the epidemic, they may extend that, but right now it's just one additional benefit period of 100 days. Next slide, Jen. So now that we've understood what the 3-day waiver is meant to do and how it can be applied, if you decide to use a 3-day waiver for whatever reason, there's a couple of things that you probably want to just operationalize or think about. And the first one is making sure that everyone's on the same page when we're talking about, the resident being at a skilled level of care, and what day does that skill benefit period start. So establishing, collectively within the IDT, what is day 1 is going to be important so that everybody's operating off the same assumptions on a go-forward basis. So once you've determined, when's the first day of the stay, now you can figure out, when do I need to set my assessment reference date, because I'll need to do a 5-day in order to access the Medicare benefit. So, important to know what day 1 is, because that sets the schedule for your 5-day assessment timeframe selection. You want to remember, sometimes people forget this, when they pick people up, they say, okay, fine, we're going to do it. We start the assessment, but they forget to go back to those basics. You do have to have an order, and you do have to have certifications that are written and signed at the cadence that are required for the point in their stay. You have to make sure that you initiate daily skilled notes. This is, again, sometimes that's a bit of a challenge, but all these things still need to be done despite the fact there's a waiver in place. And it's really very important that the business office is not out of the loop when you're looking at these types of things, because they're the ones that are going to generate the bill that goes to CMS. And right now, when we're invoking the 3-day waiver, there's a special designation code that your business office folks need to put on the bills in order to alert CMS that this bill needs to be looked at with a different set of eyes or through different filters, because they're accessing a waiver. Right, so they want to just make sure that that's identified. Otherwise, you would just get it rejected and you'd have to go through that whole process again. So make sure that they're a good, solid partner in this process. And really, the best practice, just in talking with people who've been through regional disasters and things that have happened to them in the past, is that when the emergency is over and we sort of get back to business as usual, and down the pike we start getting these reviews, if we don't have good documentation in the medical record, it's hard to recreate what may have happened, right? There's turnover in all sorts of departments. It's just really hard to, even if you could remember, there's a lot of things going on. So really a best practice is to write a good admission note, when you guys decide what day 1 is, write the reason for skilling in there, give the description and the salient information about the resident in there. And there's nothing wrong with saying you're invoking the 3-day waiver based on the national emergency, the COVID national emergency. Put it right in there so that in the event someone has to come back afterwards and make sense of it, it's available and right in the documentation for you. So that was the 3-day stay waiver. Fairly straightforward, but a lot of little nuances that you need to attend to in order to use it effectively and not, have monies clawed back at a later date. The other waiver that really is important for skilled nursing facility teams to know about and pay attention to is the MDS submission waiver. And there's been a lot of interest in this. And it's really the intent behind it is to provide some breathing room from folks that are completing the MDS and submitting the MDS in the event that that you really have to be paying attention to patient care, right? Patient care first. But there's some requirements that, because of the way they're implemented in law, that the waivers cannot change. So although the timeline requirements can be, waived, the assessments still need to have assessment reference dates within the appropriate timeframes. So you still need to set the date. And you want to make sure that you attend to that. You will have to do the MDSs eventually. We don't know right now when that will be, and when the emergency is declared over, how long it will take to come back into compliance. But you'll have to do them eventually. And for a lot of people, the thought, folks may not realize that you cannot bill Medicare unless you have an assessment, right? An MDS has to be submitted to CMS in order to be billed. And so, thinking about those things sort of helps with deciding whether or not this is the best move for you. So some of the considerations you want to think about if you're going to employ this delayed MDS waiver is to remember that, eventually they're going to have to be done for payment. So it's a balancing act with how busy are you now, how focused do you need to be now on patient care or other things outside of the MDS, and how much time do you think you will have later to catch up on them. So that's going to be a little bit of again, a judgment call on your part when you look at what your caseload is, what your emergency looks like in your center. And I've heard from a number of folks that their census has dropped in the SNFs, that folks have been in the hospital, kept in the hospital longer, bypassing SNFs, all sorts of things in that way. So if you do have a lower census, again, with an eye to resident care, do you have the opportunity to still get assessments done? Because what's starting to happen now in parts of the country, I know I'm in Maine and they're starting to do this now, the elective surgeries are opening up. And so you may, be okay now, but once you have those additional MDSs that you'd have to complete, you might be a little bit overwhelmed. So again, think about what your caseload looks like now, what your cadence looks like, and can you maintain it without, again, causing distress in patient care. And then the last bullet point here is this accelerated and advanced payments program that Medicare put out, where folks were able to get some money up front sort of as a loan kind of thing in order to keep the lights on and things moving along. And eventually those MDSs are going to have to be done to repay the dollars that were advanced. And they can do that a couple of different ways, but there will be a time when there's going to be a true up, and SNFs will either get additional funds or they'll have to write a check for the balance. But making sure that you're coding the MDSs appropriately and submitting them will draw down against that loan amount when they start to true up at a later date.
A moment of reckoning, Pam.
Exactly.
We're looking forward to that.
There's no free money.
Unfortunately not. So we're just going to pause for a second and thank you for that, Pam. It's certainly enough to chew on, and that's not even close to everything, but it's enough to start with. So we do have a couple of polls to kind of take your temperature of the folks who are attending this webinar today. So is your center, I should launch the poll. There we go. So it is active now. So you'll see that in your toolbar. And just click your options. So your options are, yes, we are using the MDS submission waiver. We are just flat out, all hands are on deck, and nobody's available to complete these MDSs right now and submit them. No, we are the lucky few who have been able to keep up, and good for you. Hope it stays that way. And C is not anymore. We did have to do a delay while we were getting our feet back underneath us, but we've managed to get on top of our situation, and we're catching up right now. Again, hopefully that will stay that way so that you don't have a big amount of work to true everything up after this is all over. So I will give it a little bit longer. Leave this up for about a minute. Okay, so it's been up for a minute. Everybody was quick to answer. And so here's the answer. Vast majority of everybody, again, and we actually did ask this question in an earlier webinar, and we were surprised that so many were able to keep up, but very good. And I know I'm an MDS coordinator, so I know that nothing hurts more than a backlog of MDSs, so I don't blame you. 17% are all hands on deck, and they are just doing everything they can to provide care right now, totally understandable. And 7% are working on catching up now. So good for you guys to get a little bit semblance of normality back into your process. So thank you for that. And we're going to move on. Oh, I have a little duplicate here. Sorry about that. So I'm going to take over now and talk about skilling in place. And by skilling in place, I mean exercising that 3-day waiver that Pam explained for us, and taking a long-term resident in your facility and getting them onto your Medicare skilled caseload. So the key to this, of course, is identifying those skilled needs, because you don't have that 3-day qualifying stay to get the ball rolling and say, okay, well, this resident's going to be skilled for rehabilitation after cardiac surgery. You don't have that piece. So once you determine that, yeah, it looks like this resident is going to need to go on Medicare skill, then you need to, as Pam said earlier, determine day one and get that documentation ball rolling to capture that skilled need. And this is one of those cases where the observation and assessment and management and evaluation and teaching and training, all of those pieces, yes, you're most likely going to have quite a bit of direct skilled nursing care going on, but perhaps not so much of that skilled rehabilitation, depending on if that particular resident is in isolation or on a cohorted unit, and you're doing your best to maintain as much distancing as possible in your facility. So think about the other areas that you're going to be assessing anyhow every time you look at a resident. What was their potential for exposure to COVID-19, and both in the past and going forward? Do they have any signs and symptoms? What are you watching for? Are there other comorbidities? Does this resident already have COPD? Are they already post-stroke or something like that places the resident at even more increased risk, and you would want to watch for other specific areas that would be impacted. Other areas that may be impacted that you might not necessarily think about right now if you're just interested in keeping the fever down and keeping them breathing. But there's restricted mobility, potential for significant functional decline going forward, social isolation, and the disruption to the daily life in the facility, particularly for your long-term residents whose home this is, and their regular routine has just been turned upside down. Potential for weight loss if you no longer have communal dining and getting people to have snacks at activities all day. How much food is laying around a nursing home most of the time. Definitely potential for weight loss. And other rehabilitation needs, as I mentioned, post-COVID-19, the picture for rehabilitation either under Part A or Part B going forward is going to be significant for the deconditioning that would come from this post-illness phase. Again, observation and assessment, management and evaluation, and those direct skilled services are all pieces, cogs in the machine that are running on a day in and day out. And you want to make sure you're capturing that well in the documentation, so that, either it gets captured on the assessment, so you get the appropriate PDPM classification, or if you have to go back and do that MDF later, that it becomes doubly important to document. So I've got a few scenarios here, to skill or not to skill. So this is not going to be a poll or a quiz, just, answering your head. Hopefully you agree with me. So if we think of scenario number one, we have a long-term care resident. She's not on any therapy or any skilled nursing services. She's just happily in place in the facility. But unfortunately, she develops symptoms. She's got a high fever. She's coughing. She's very fatigued. You know the drill. So, out of an abundance of caution, the SNF places the resident in a single room isolation room, and the physician orders a COVID-19 test, which thank God is available in the facility, and treating the symptoms going forward, even while the test is pending, and monitoring for further decline. And the test results come back positive. So this one is pretty straightforward. You would definitely skill this resident because of the active acute COVID-19 infection. You would make sure that you have the ICD-10 code captured in the documentation so that you can put that down as the primary diagnosis, because that's the reason why this resident is now on skilled services. Scenario two. So we have another long-term care resident, not her roommate, but somebody else on the same floor, not on therapy, not on skilled nursing services, but they also develop symptoms. They've got a fever, the cough, the fatigue, but the facility doesn't have any further isolation rooms available because they're all used up. So they go to the next best option, which is cohorting together with other residents that are symptomatic for COVID-19 to try to restrict the spread as much as possible. Same drill, the doc orders testing, treatment, monitoring, et cetera, but the test results are still pending. And the lab has a huge backlog, and it's been a week and you haven't gotten the test results back yet, which of course is happening, unfortunately, quite frequently. Well, guess what? You can still skill. You don't need a diagnosis to skill. What's important is the level of care. And you also don't need isolation. Isolation is not a qualifier for skilled care, although it will categorize as an extensive services in the PDPM categorization, but it's not necessary. What's necessary is all the other stuff that you're doing to manage this resident's care at a skilled level. So yeah, go ahead and skill. So the next scenario, and this is actually, I just caught out of the corner of my eye, a question came through, and the question is an answer feature. So rather than answer it separately, hopefully this scenario will answer your question. So we have a long-term care resident, had a CVA several years ago, dysphagia, 100% tube fed, just cannot swallow. So all nutrition and hydration is coming through the tube. And the last time they got their Part A benefit was 9 months ago. And he develops the symptoms, unfortunately. Now there is a single room available for this resident in isolation. They prioritized him because he is so very compromised and on the tube feeding and immobile. So placed in isolation. The testing and the treatment and everything was ordered by the physician. All of that is in place, and the test results are positive, COVID-19, unfortunately. But no available benefit period. This resident never dropped skill in the 9 months since the last time he accessed his Part A benefit. So this is one of those long-term skill patients, whether they had continuous tube feeding, continuous vent, continuous rehab under Part B. If they continued to have those skilled services and didn't have that 60-day break or even begin that wellness period, as Pam mentioned earlier, you only need 1 day to start that wellness period under the waiver. This resident didn't have that. So unfortunately, he doesn't have a Medicare benefit to access right now. And last but not least, so we have another long-term care resident. This facility's very busy right now. Had a fall, went to the ED, and they broke their wrist, unfortunately, because life continues to happen in the skilled nursing facility. And if somebody breaks their wrist, they have to go out and have it fixed. So they had it reduced, a cast was applied, no surgery needed, and the resident came back to the SNF within 24 hours. They didn't even have to be admitted to the hospital, fortunately, to prevent infection. So, and the physician orders PT and OT 5 days a week because they have the available resources to be able to provide that therapy. And no signs or symptoms of COVID-19. Somehow they dodged the bullet, no suspected exposure because of how very carefully this situation was managed. And all the COVID-19 cases are cohorted way over on another unit. So we're fairly safe with this resident. Well, in this case, yeah, you can skill, because you're skilling for the therapy. This is, again, this is kind of a normal scenario that we're all kind of missing right now. But this is a normal situation, and the waiver applies because most likely a big part of the reason why the resident didn't have that hospital stay, they were not admitted to the hospital in the first place, is to keep people from being admitted to the hospital as much as humanly possible and to reduce the burden on the hospitals. So you don't need a COVID diagnosis to access the benefit under the 3-day waiver. And that's enough with my scenarios. So, of course, the waivers don't change the requirement to make sure that you are documenting that daily skilled care, particularly when it's something as tricky as monitoring and managing a care plan in the absence of even an active diagnosis because you're waiting for the labs to come back. So making sure you're documenting that daily skilled observation and assessment that your nursing team is completing, respiratory assessments, respiratory treatments, any medications that are being provided. Of course, the test results, any changes in condition, new physician's orders, and remember, don't forget the other areas out in the outfield here, monitoring dietary intake. You might have to initiate additional supplementation, the decline in mobility, signs of depression, of course, are a huge area of risk. And special precautions, even if it's not strict isolation because you don't have any isolation rooms available, but the special precautions that you need to put in place, just continue to document that you're maintaining those as well. Now, you don't have to go overboard with the documentation because you're busy enough, but one good daily note per resident on Medicare caseload is enough to substantiate daily skilled level of care. And of course, if anything happens in between those notes, you would put in a short addendum or a note in between shifts. That's fine, just as long as you have something per day. Now, how long do you keep somebody on skilled level of care? Well, this is kind of a cop-out answer, but as long as they meet the skilled level of care criteria. So you know how it is when you decide to drop skill. It's a little trickier when they're not on therapy, but once they no longer require that daily monitoring intervention, perhaps you've got your 2 negative lab results through, you've moved them out of isolation, you're sweeping up after all of the issues that the resident had, then you would go ahead and agree on a last covered day, follow your policy for issuing that notice of Medicare non-coverage. So, the example, somebody who has recovered from COVID-19, they've got their 2 negative test results, and they no longer need the monitoring for signs or symptoms. They're all set, no more skill. Or we have the resident who had the previous exposure, so you're isolating them and monitoring them while you are waiting for those tests to come back. But the test results come back negative, and throughout that surveillance period, they didn't develop any symptoms. So hopefully that was accurate and they were not infected, but you can no longer skill beyond that. And of course, for the resident, the person with the broken wrist, Once they're finished with their skilled level of therapy, then you would discontinue. And if there are no other skills under the nursing bucket, then you would discontinue that skilled level of care. Very important to make sure you do that, though, at the appropriate time, because otherwise you're at risk in a big way for compliance. So I'm going to hand it back over to Pam now.
Thanks, Jen. Those were great examples, I think, that people can really use to noodle over, whether someone should be skilled or not. And the reason that we need to do that and really be thoughtful and document our decision-making process is because people will be looking. And just recently, recently as the last week in May, the Office of the Inspector General issued out what they call a strategic plan. And it's titled The Oversight of COVID-19 Response and Recovery. And you can probably imagine when, the amount of money that has been going out to try to stabilize delivery of care, stabilize the economy, and stabilize, the infrastructure, that there's, outside of usual channels, that there's going to be scrutiny of where that money has gone, and accounting as to where it's been used, and all sorts of things like that. But basically what the OIG has consolidated it into conceptually are these 4 goals. The goal is to protect people, protect funds, protect the infrastructure, and promote effectiveness. So they've boiled it down to 4 categories, but underneath each of these categories, they have several, many steps, types of things that they're going to be doing in order to ensure that the money spent, the outcomes expected, all meet the expectation from the release of the funds. So I'm just going to talk about the couple of the goals that have implications for the post-acute care skilled nursing facilities. We're most directly impacted by 2 of the goals. The first one is protect people. And what the OIG is committed to do is to fight fraud and scams. They will be looking for suspected fraud in this time, particularly looking at the HHS, home health services systems, tongue twister there, and then the beneficiaries that might be exposed to fraud schemes related to COVID. And you can probably imagine this already. There's been a lot of concerns about the testing, the quality of the testing, the quality of the test kits, those sorts of things. And also, people being warned about identity theft, and there are easing in some of the restrictions about how we can use HIPAA information. And so again, sensitivity on the part of the OIG to make sure that frauds and scams don't get any traction. They also will be assessing the impact of the programs on the beneficiaries and the public. So this means, again, audits and evaluations. And really the first bullet here, where they mentioned selected healthcare settings, it's going to be SNFs. They did directly mention in the plan skilled nursing facilities as an area or a setting of interest as they're doing their audits and evaluations. So they're not only auditing us, they're also auditing HHS operations. So they're checking the checker kind of thing. So they're going to be looking at how are the resources distributed under the auspices of HHS. What's the story with the test development, research and development around the vaccine? They're really looking at all these areas. And again, these have implications for us for goal 1 under protect the people. And then goal 2, which is probably jumped out at most people, is protect funds. And again, when you have this much money in the system and regulations changing very, very quickly, it's easy to get caught up. But they're going to be looking for, detection and prevention of misspending of funds, and they will identify remedies in the event that they do find that things were not allocated appropriately. They will be doing audits of the oversight from HHS and the distribution and use of the funding. So where the government is making decisions about where the money is going to go. And they're also going to be auditing the post-acute care providers to make sure that we're using that money in the way it was intended to be used, that we're reporting how we're using it, that we're reporting information that's required to be used in order to do that. And then also recommend recovery in the event that they find misuse or misallocation of the funding. And then the third element in this area that's of interest is that they are determined to work with other governmental entities, law departments, any other folks that will be out there looking to identify, detect, and prevent fraud, abuse, and mismanagement. So they're going to kind of circle the wagons and make sure that everybody's got their area to review and make sure that the T's are crossed and the I's are dotted as needed. And they really are concerned, as I think anyone would be, about funds going in the wrong direction. So they'll be looking very carefully at that. So obviously, there's implications for SNF providers, right? When all these things are happening, and we know what OIG is going to do, and we know what CMS is doing. It's, some things become pretty clear that we need to be ready for Medicare audits. They're coming. We just don't know when, but they will come. They did it. They being CMS. The RAC auditors, the MAC auditors were all over any of the other regional disasters. There were lots of reviews, making sure that things were done correctly and paid appropriately. So we need to be ready. And remember, as we've said multiple times, you have to have a completed MDS submitted to CMS and a UB billed in order to get the cash from CMS. So the MDS has got to be completed and submitted. That informs your UB04. You also want to make sure that when you're exercising your waivers, that you're using that disaster-related condition code. Again, the idea is that it sets aside that UB for a different kind of review, different filter, rather than a traditional one that would go through the conventional filters, looking for a 3-day stay, looking for stay dates and documentation. So you want to make sure that that's all consistent. And I don't want anyone to get lost in all this, buzz and concerns about other things. But, as Jen mentioned, you have to have the documentation in place to use it to support your MDS. So even if you're not doing it now, you have to make sure that people are documenting the information, because going back later to do it is going to be hard. People's memories will be different. So really making sure that the supporting documentation gets into the medical record so that it can be used. Don't forget to set the ARD within the time frames required. Make sure you document the specifics about that 3-day waiver. So if you, for whatever reason, call your Medicare administrative contractor because you have a question, because you have a concern, make sure that you document thoroughly what they told you and what your steps were. So if there's any question on the other end, you have it right there for you. And also be very careful that you're watching, because remember, these waivers are only in place while we are operating in a state of emergency. So if that state of emergency is retired or rescinded, you need to know that at that point in time, whatever the start date is, you need to start over with the regular Medicare process. And as we probably all know, we have to be ready for an infection control scrutiny. Memo June 1st, so just this week, came out where they were issuing guidance to the states because they felt as though the states weren't doing enough to ensure the safety of the residents in SNFs. So what they said is that the states need to conduct focused surveys in infection control in 100% of their centers by July 31st. And this was because when they looked at the surveys that had been completed up until the current, the end of last month pretty much, they saw that some states had done very few and some states had done a whole bunch. So they've level set that everyone has to have all their centers audited in infection control by July 31st. So if you have not been audited yet, you will be. The same with on-site surveys within 30 days of the memo. So that's the end of beginning of July. They have to go back and audit centers that had previous outbreaks. So if you are the unfortunate center that had a previous outbreak, congratulations for getting over it, but you will have a visit from a surveyor at some point. And then if you have new cases that develop, 3 or more new cases, a survey will have to be done within 5 days of that report of 3 or more new cases. So lots of focus on infection and lots of focus on audits. Going forward for fiscal year 2021, they're mandating that the focused infection control surveys continue, and that states do 20% of their SNFs under this guidance. We saw the information on the enhanced enforcement for infection control diseases. These are very hefty fines, and it's, things you really want to step and take notice. They're looking at lower scope and severity as also having giving more weight to any citation in infection control. And they created 2 new tags as well: failure to notify the CDC or failure to notify families of COVID-19 cases.
Sorry, my mute wouldn't come off. So we have one more poll for you, so that we'll launch this here. Has your facility had an infection control focus survey yet? Simple question, it's either yes or no. So let's see. Ooh, more than half of you on this call right now have had one so far. Hope it went as well as possible, since you're obviously on top of your infection control policies right now. If you weren't before, you are now. So hang in there for the 40-something% who haven't had one yet. As Pam says, be prepared for that to happen again. So I am just going to give it a few more seconds. We are actually just about ready to wrap things up. So thank you for hanging in there with us. Okay, I think we are about ready to close here. So we ended up with 58% of people on the call had an infection control focus survey, and 42% have not yet, but you will. So thank you for answering your question, and we will move back to my screen here. Just to wrap things up, actually, so we've covered all the content that we were going to discuss today between Pam and myself, but we did want to leave you with some sources because there are a lot of them, a lot of pieces, and continuing to be added. So the CMS FAQs. I do want to point out the second option there is from the New York State Health Facilities Association, or NYSHFA. They have an extremely comprehensive document that lays out all kinds of scenarios for whether or not to skill a patient under Medicare during this situation and with the waiver. So I think I found that really, really helpful. And information from the OIG and billing and the COVID-19 focus surveys. So lots of resources for you to cover. And as we wrap things up, we do want to remind you that, we are with you. We're doing our best to help you and support you with education and timely information. And if you have good stories to share, please tag us in your social media or share with us so that we can continue to spread the word of all the hard work and all the everything that you are doing to care for your residents and families and staffing your facility during this pandemic. So feel free to reach out to Pam or myself with any questions. There were a few questions here that we will follow up via email after the call. So your contact information is here in the handout if you haven't downloaded it yet. And we are approved for 1 contact hour for nurses and 1 contact hour for nursing home administrators. So in order to get your contact hour, you do need to fill out our SurveyMonkey. So the link to that is up on the screen. It's not clickable. You need to copy and you need to write it down and put it into your browser. Or we will also be emailing this out in a link in an email once we get the attendance record from GoToWebinar. So fill out the survey. If you've got multiple people attending in the same room, have them, or in the same building, have them fill out the survey as well so they can each get credit for attending. And we'd like the surveys to be completed within a week. So for nursing home administrators, please make sure you give us your NAB ID number so that when we report to the NAB CEU registry, they'll have your information. And I'll leave this up here for another moment or so, but we have used up our time. So thank you very much for your time today. We appreciate everything you're doing here. We hope this was helpful to you. And we will be speaking with you again at another time. And thank you, Pam.
Thank you, Jen.
All right. Take care, everyone.